Hello everyone. The topic for now we will see is interocclusal records in fixed prosthodontics. Firstly, interocclusal records. That means records which is between the maxillary and mandibular occlusal. That is between the two arches. The record which is taken is called interocclusal record. And in fixed prosthodontics, why are we learning it in fixed prosthodontics? Even we will see that. Now for that, first let us know what is an importance of this entire interocclusal record for fixed prosthodontics. Now we have maxillary cast with us. We have mandibular cast with us. Now the basic question remains here is mounting the maxillary cast with that of mandibular cast. Now how will I mount a maxillary cast, or how will I mount any two things if I don't have an orientation? So to get that orientation between, or the relationship between the maxillary and that of mandibular cast, interocclusal record is important. So we have two casts, we have interocclusal record between us. So I can put that interocclusal record onto one of the cast and place the other cast over it. Now that will be depicting my exact relation how it is in the mouth. So that is the reason that is the importance of interocclusal record, mainly to orient it into the articulator. Now what are the different characteristics of an ideal interocclusal record material? First we need to know that. Then we will see what are the different interocclusal record materials. Now limited resistance should be there before setting to avoid displacement of the teeth or the mandible, right? We cannot have to have more resistance. It should be least resistance before setting. And after setting, what it should be? It should be resistant. It should be rigid, resilient after setting. Main thing is this, that it should be rigid, that it should be rigid and resilient after setting. And before setting, it should be limited resistance should be there. Resistance should be there. Minimal dimensional change should be there after setting, because after setting of the material we have to use it in the laboratory, so that time period will be there, so it should not distort in that particular time. Accurate record of the occlusal or incisal surfaces of the teeth should take place. Most important, it should be easy to manipulate, it should be easy to mix. The record should be verifiable. It is not that once taken and it's all done. No, we can have to verify that particular record intraorally as well as on the cast. So verifying of the record is very important characteristic of interocclusal record material. So what are the different interocclusal record material that we have? We have waxes, we have zinc oxide eugenol, we have thermoplastic materials, we have elastomeric materials, we have impression plaster, acrylic is also used. Coming to the first one, that is wax. Wax. How and what wax? Now we have physiologic waxes which is not resistant before setting, which flows nicely before setting, and it sets fast, and after setting it is rigid. Now example, alu wax. Now that we use as the interocclusal record material. Now those bite registration wax, you can see here it is in a shape of a maxillary and mandibular arches. You place it over the teeth. You first soften this, place it over the teeth, ask the patient to bite over these waxes and hold it and then remove it after it is set. Now important thing is, I spoke here one word, bite the patient. Ask the patient to bite. What he should be biting in? Centric relation or maximal intercuspation? We'll come to that question later. Let's see the material first. Second material is zinc oxide eugenol paste. Now this is another widely accepted and used material, that is zinc oxide eugenol paste. The normal zinc oxide eugenol that we use to make the secondary impression is used. What we do? We mix the impression paste and place it over the mandibular teeth and then ask the patient to bite. Now the problem with zinc oxide eugenol is it has got an enormous amount of flowability, of viscosity. So now what happens? The setting of the material takes time. So the patient's work intraorally is increased, the time is increased. So hence, it is difficult for a patient to keep the mouth open for a long time, and most important, the smell of that eugenol, which is very irritating, and oil of clove, which is acidic in nature. So hence, zinc oxide eugenol is not used as many as time. It is used mostly in complete denture for recording of the centric relation. We do it in nickel notch method. We do have in these days elastomeric bite registration paste. Now this can be adhesion silicone or it can be condensation silicone. You know, only these two are available. Now which is more stable, additional silicone or condensation silicone? So it is very known fact to us from dental materials that adhesion silicone is more stable, more accurate and more lasting in its accuracy than condensation silicone. So we need to use adhesion silicone if we are using it for after long time. Like you have to use it after 2-3 days, you have to use adhesion silicone. Condensation silicone distorts and dimensional changes starts within 24 hours. So we have these elastomerics. Now you see these are the tips which is present and these are the bite registration material which is there. So now you need to put these bite registration material over the posterior ends of the mandibular teeth. Then ask the patient to bite. Important thing to note about elastomeric impression material or the bite registration material is it sets very fast. So what we need to do is our work should be very quick. Before setting, it has got limited resistance, true. But the rigid and resiliency after setting is also very high. So that is the reason elastomeric bite registration is the most widely accepted, truly in its accuracy, and dimensional change does not happen and no distortion happens even after the only problem with the elastomeric impression bite registration paste is elastomeric is compression is not there. When you compress, it will rebound. So what happens if your seating of your maxillary cast is not proper, it will rebound. And a wrong relationship is established between the maxillary and mandibular cast onto the articulator. So we need to be careful about that. Coming to impression plaster, used in earlier days, nowadays it is not used. Reason is that the setting of the plaster takes time. It is very difficult to use. It is very chippy and very uncomfortable for the patient. First thing. Second thing about impression plaster is that it is very brittle. It breaks off. Once it is set, once it is taken out, and if it breaks off, patient is also gone, articulation is also not happened and the work is all empty. So our work is not complete. So impression plaster is very brittle. Now these impression plasters hence are added with some modifiers. They add some modifiers in that so that it increases the strength. So modifiers are added so that the strength of the impression plaster is increased, but though impression plaster at the end of the day is very uncomfortable for the patient, very cheesy to be putting into the mouth, and most important, the flow of the material is very high. So before setting it flows very fast. So what happens in the mouth, it can go away in the tongue area or in the can create gag in some patients. Impression plaster is one of the most important material which gives away gag in the patients. Acrylic resin nowadays, which is used again, is acrylic resin. But the problem remains with acrylic resin is two things. First, polymerization shrinkage takes place after the material is set. We all know that acrylic resin undergoes polymerization shrinkage. Second is the heat, the exothermic reaction which it liberates during the setting of the material. So once the material is setting at that point of time when we have put intraorally, it will liberate more heat. So that will be very dangerous to the underlying teeth, to the periodontal ligaments, to the mucosa, to the tongue, to the patient. Everywhere it is heat. So it is very uncomfortable for the patient to bear that particular exothermic reaction which comes over the acrylic resin. And even after it is set, it gives polymerization shrinkage. So dimension stability is into question mark. So again, this is not a good material to be used. Now what is the purpose of using an interocclusal record material? As I told you very early in the introduction of this particular topic was, Interocclusal record material, as the name suggests by itself, is a record material which records the relationship between the two arches. Interocclusion. So maxillary and mandibular occlusion, the relation is established with the help of this material. Why do we need to do this? Because after the patient is gone, we need to know how his maxilla and mandible was aligned. To prepare fixed partial denture, we need to know the centric relation record as well as the long centric record. Single unit, forget it, not required. For single unit, you can go for maximal intercuspation position record. But if it is a multiple fixed partial denture which has multiple units, in those cases, not only centric relation, also you have to establish a long centric between the centric relation and maximal intercuspation. So that establishment will require exact mounting based on the interocclusal record with the maxillary and mandibular cast on the articulator. So classification of interocclusal record material can be classified on the different records that we take. Centric record, eccentric records, and protrusive or lateral excursion that comes under eccentric records. Centric records can be of centric occlusion records or centric relation records. All of these are different. What are these and why are these for? Let's come to one by one. Centric relation record. Now, centric relation is what? It is a maxillomandibular relationship in which the condyles articulate with the thinnest, as you can see the diagram, the condyles articulate with the thinnest avascular portion of their respective disc, where it is superior anterior in position, and this position is indiscernible with the tooth contact, and it is clinically indiscernible when the mandible is positioned superiorly and anteriorly. So that means that this particular condyle, when it is articulating with its thinnest avascular portion over here in the superior anterior position, that is centric relation position. How will I guide my patient to centric relation position is another question mark. So different scientists again came over different techniques and different theories. Now the first one was chin point guidance. What you do in chin point guidance? The posterior and superior positioning of mandible due to pressure on the chin is applied. You take your thumb, you put it over here, you take your fingers and support your mandible. Now you press the mandible posteriorly, upward, superiorly. So in that way, you will guide your chin or the mandible to the superior anterior position or the centric relation position. That has to be done with very forceful application, can be done with single finger or can be supported with two fingers and done like this. Now during these management of getting the patient's mandible to centric relation position, most important thing is you're not supposed to ask the patient to sit straight. You're supposed to ask the patient to go supine like this and then sit. So what happens in that, you're keeping supine position, so this is getting hanged by itself. It is loose, the muscles over here gets loosened up because when you're straight, gravity is falling over it. So there is an adverse force of tonicity onto the muscles. Now the muscles are not relaxed. When you keep it like this, it is somewhere going near to the physiologic rest position as well as going to the centric relation position. This is how chin guidance, chin point guidance. Next is unguided method. What is unguided method? When the patient is not touched by the dentist. How will I do that? I will not touch the patient, but the patient will go to centric relation. Yes. How? First important thing is, our entire mouth is very much habituated to whatever we are doing in day-to-day life. Like for example, if I'm standing here, my mouth will close in maximal intercuspation position only. While I'm chewing my food, it will close in maximal intercuspation position. So I need to say these muscles that stop your activity. I need to say my muscles over here, which is present with the temporomandibular joint and the facial muscle of expressions, that you need to stop your activity, go into physiologic rest position. How will I say that? Now for that, I need to deprogram the muscles. Deprogramming. How do I do deprogramming of the muscles? Now deprogramming can be done of various methods. There are methods like there are leaf gauges which are available. You put the leaf gauges and you ask the patient to go slightly close the mouth, and feather like touch on the leaf gauge will automatically make the muscles relaxed. Or you put two cotton rolls in the premolar region and ask the patient to keep the mouth closed with the cotton. So now the muscles are getting relaxed and it is deprogramming. You can make Lucia jig, that is anterior jigs are present. You can make those, this is this kind of thing that you put in the anterior mouth, and when you ask the patient to bite, the patient cannot bite totally because there is a maxillary teeth, there is the Lucia jig which is there. Now mandible teeth will come and hit on the Lucia jig, so there will be gap posteriorly. So again deprogramming is happening. Basically we are making the teeth forget its home position, to be very frank and simple. So that is unguided method. By that what you will do? By that you will let the patient go into the centric relation position. You ask the patient to touch his tongue onto the posterior palate. After deprogramming, then the patient goes back to the centric relation position. Dawson came up with his new technique, or his new technique in those days. It's a very old technique right now. Bilateral manipulation method. Now what does this bilateral manipulation method says all? Now this says that what you need to do is you first make the patient sleep in a supine position. Not entirely supine, semi-supine position. When you ask the patient to sleep in semi-supine position like this, and then with the help of your two fingers and your index finger, you will manipulate the mandible and take it back. Now you will first put it down and then superiorly, posteriorly you will press the mandible out in a forceful direction. Now then we will guide the mandible in the centric relation position, and in that there will be not closure of the mouth completely. The teeth will not close, maximal intercuspation will not happen. So whatever happens, there you will put your record bite material, may it be elastomers, may it be wax, may it be acrylic or anything. You put your material as per your choice and your decisions, and then you will keep the position, remain that position. That bite material has come out. Now in those bite, we have got the imprints of maxilla and mandible. Important thing to note for centric relation record of bite material, there will not be any perforation of the registration bite that we are taking. No materials will be perforated in centric relation because there is already a gap. How will it perforate? For perforation it has to be contact. There is no contact for centric relation. So it is indiscernible of tooth contact, we know that. So what is happening now? We have gap in the interocclusal record material all over where centric relation is recorded. Now we have the cusp imprints on the maxilla on the upper side, mandible on the downside. We know the functional cusp of the maxilla and mandible. Very nicely in those areas you can add zinc oxide eugenol, little paste in those areas, and again ask the patient to bite. Those zinc oxide eugenol which has flown outside, remove it with a sharp instrument, and then your entire interocclusal record with the functional cusp markings are ready. Now let's see what it all says. This is what is a bilateral manipulation method by Dawson. So let's see. According to theory how it goes. Fingers are placed along the inferior border of the mandible and both the thumbs are placed on the mandibular symphysis. As I told you, hold it like this. Before all this thing, the patient is asked to sleep in the semi-supine position. That is most important. Softened base plate wax is adapted to the maxillary arch. On each side, cuts are placed between the lateral incisor and canine. Why is this important? Cuts are placed between lateral incisor and canines. Orientation. Because you will cut that area and you will fix the wax onto, you will lap the wax onto the laterals. So whenever again you will remove and again put back, now you have an orientation where exactly it's supposed to go. Orientation tab, that is, see what is we told. Orientation tabs are formed over the labial surface of each canine. These cuts are extended to remove an anterior wedges. Excess wax outside the buccal cusp is also, tip is also removed. So after this is done, then you take out the material, and then in the functional cusp area you will add zinc oxide eugenol paste, and then again you will close it with the help of orientation tabs, and then once you remove it you will have the entire registration of the centric relation record. Now the next one is a maximal intercuspation record. When do I need this? Maximal intercuspation is required. Single crowns, not required to go ahead with doing so many centric relation records and exerting the patient, exerting yourself, exerting the lab personnel, confusing everybody. So now that cases we can go with maximal intercuspation record. Very simple. These trays are known as triple trays. What is this triple tray means? triple, matlab 3 things. What are the 3 things? There is a plastic sleeve here, you can see. Down we will put an impression material, up we will put an impression material. So 1 impression on the up, plastic sleeve, 2, third is the down impression material. So in 1 triple tray you can take the bite of that particular section. Single crowns, in those cases these are very helpful. So bite registration form, the tray is tried in patient's mouth, registration paste is injected over the top and bottom of the bite registration tray, the loaded tray is placed into the patient over the prepared tooth. Reverse, remove the excess material of the tray border, excess thickness of the rounded off with burr. Only imprints of the cusp tip should remain in the trimmed border. The part of the record facial to the mandibular cusp tip is cut off. The record placed on the mandibular cast. The cast is articulated with the record. The mandibular cast is mounted on the articulating using the record. What is all this? What it said is, I told you very clearly that we have to put 1 material on the top, 1 material on the down. Now once we put these materials, now we will ask the patient to bite on this. Will it get perforated? Yes, of course it will get perforated. Maximal intercuspation, maximum contact, of course it will get perforated. So once it is getting perforated means there will be excess material which will come out from this side and that side. So now excess material which has come out, you will trim it off from both the sides. Now what is remaining inside is just the cusp to cusp relation. The fossa to cusp relation you can rather say. So that is remaining inside this triple tray. So that you have to take and place this tray onto the mandibular cast or maxillary cast as per your wish. Place it on one of the cast, mount it with the articulator, then place another cast onto that triple tray and mount it on the other side. Your mounting in a maximal intercuspation position is done, and that can be done on a 3-point articulator or a mean value articulator as well. Whereas a centric relation record articulation cannot be done on a mean value or a 3-point articulator. It has to be semi-adjustable articulator. Coming to lateral interocclusal records, why do we need lateral interocclusal records? Like right now I told you, when you are doing centric relation records, that has to be mounted on semi-adjustable articulator. Now for that, when you are taking a centric relation record, that will give you what? That will give you very clearly about the centric relation position. What about the lateral excursions? Left lateral, right lateral. So again in left lateral you have to move the patient, make the bite as we have told you before, place the zinc oxide eugenol onto the functional cusp. Now because this is more important in this step, again right lateral, that's a different record. Some semi-adjustable articulators accept both the lateral records. Some semi-adjustable articulators do not accept. Like Hanau H2 do not accept. Whitmix accepts. So based on the articulator that is available to you, you need to fabricate and you need to, manipulate the record which you want. For Hanau H2 you do not require lateral records, you directly need a protrusive record. We'll come to that. So patient is guided into working excursion on right and left side, and interocclusal record is made with a wax buffer. Now this is also called wax buffer. The interocclusal wax registration bite is also called wax buffer. Protrusive interocclusal record, as I told you, some articulator like Hanau H2 will take protrusive record. For that you have to ask the patient to bite H2H, get a protrusive moment and then make the wax buffer sit in its place and then ask the patient to bite, all in semi-supine position, and so then you will get the protrusive record. But now, what is this protrusive record we are going to achieve with? Why do we want protrusive interocclusal record? As we know, we need to have condylar guidance of the patient. Now, the condylar guidance of the patient will come from protrusive interocclusal record. So, after having the protrusive interocclusal record, the important thing, that is, the articulator is now manipulated to find out which is the condylar and how much is the condylar guidance of the patient. So condylar guidance is achieved with the help of protrusive interocclusal record, where programming of the articulator will start and you have to find out what is the concised and customized condylar guidance for that particular patient with the help of protrusive interocclusal record. This is all about interocclusal record, but it is important whether you do a single crown preparation or a multiple crown tooth preparation. Interocclusal record is must, because to orient the cast as well as fabricate the restoration based on the interferences, based on its working, and patients can have canine guided. Patients can have groove function. How will I determine all those things in my crown which is coming? So it is the interocclusal records which will say us and correct us in the prosthesis which is going to come, and will not give any high point in the prosthesis or any interference due to the prosthesis before tooth preparation and after tooth preparation. Thank you.